So this is the second piece of the exemplar of hypothyroidism under the concept of metabolism. Again, you will find this in your Pearson book under the concept of metabolism and in ATI under endocrine disorders. Please again pause and look at the screen. This is what you'll be able to do by the end of this lecture. Hypothyroidism is a condition in which there is an inadequate amount of circulating thyroid hormones, T3 and T4, which causes a decrease in metabolic rate that can affect all body systems. Thyroid function can decline slowly or rapidly. We think about myxedema coma, which can occur very rapidly, and it's a complication of hypothyroidism. But also some things to think about. Hypothyroidism can have manifestations that just mimic the aging process, so it can be left undiagnosed in older clients, and it can lead to potentially serious adverse effects from medications like sedatives, opiates, and analgesics, for example. You'll see a goiter. So when the thyroid hormone production decreases, the thyroid gland enlarges in an attempt to produce more hormone. This is when you'll see a goiter, for example. And in terms of etiology, there's different causes. So primary hypothyroidism is really just a dysfunction of the thyroid gland. It's common in the disease of autoimmune thyroiditis. It can be used the result of medications that we do on purpose. So for example, remember we gave anti-thyroid medications in a patient with hyperthyroidism prior to going to surgery. Or it can be loss of the thyroid gland. So again, maybe the patient received surgical removal of the gland, or they received radioactive iodine or radiation treatment. So there is no thyroid gland left, for example. Secondary hypothyroidism is usually caused by the failure of the anterior pituitary gland to stimulate the thyroid gland. So that's an example. And then tertiary hypothyroidism is really caused by the failure of the hypothalamus to produce thyroid-releasing hormone. Secondary and tertiary hypothyroidism are sometimes called central hypothyroidism, but again, most common is primary hypothyroidism. Risk factors, again, are women much more affected than men. Certain medications like lithium and amiodarone, you have to be cautious of. Amiodarone we use a lot. You've learned about lithium in NUR 180. It can result from the inadequate intake of iodine. This does not happen typically in our country. In the United States, the use of iodized salt has kind of reduced this risk, but just to make you aware, it is a potential. Hashimoto's thyroiditis is the most common cause of goiter in primary hypothyroidism. It's an autoimmune disease. Antibodies develop that kind of destroy that thyroid tissue. And then unfortunately the functional tissue is replaced by just kind of fibrous scar tissue, and then those thyroid levels decrease. It is common in women, like I said, and there is a familiar link. So for prevention, again, in the United States, it's not such a worry because we do use a lot of iodine supplements or iodine, salts, iodized salt, but if, that would be the only way to prevent it. So instead of sea salt, there's enough salt in our diet to not cause this. Clinical manifestations of hypothyroidism can occur over months and years even. It's pretty slow onset. Patients with hypothyroidism have a goiter. Neurologically, everything is just slower. They could have slow speech, their reflexes are slow, they're lethargic, they might have some memory impairment, have some periorbital edema. Cardiovascular-wise, hypotension and bradycardia. They might have an enlarged heart. Because they have excess fluid volume and weight gain, systemic edema, they might develop heart failure. Musculoskeletal, just some fatigue and weakness. Reproductive, back up to GI. Everything is slow, so even GI is slow, which means they're constipated. Reproductive, they also have infertility, low libido, amenorrhea. Skin is dry, and they have edema, and they have hair loss. with integumentary, and endocrine, they're actually cold all the time, they're hypothermic, and as long as they get treated, it can actually help control and reduce a lot of these symptoms. Myxedema coma is the complication of hypothyroidism. Um, a lot of times it is life-threatening, and it usually occurs when hypothyroidism is untreated, or poorly managed, or when there's a stressor. So, stressors that we think about is like an acute illness or infection, surgery, chemotherapy, or even the use of sedatives or opiates can actually affect a client who has hypothyroidism. It is characterized by severe metabolic disorders, hyponatremia, hypoglycemia, lactic acidosis, hypothermia, um, cardiovascular and respiratory compromise. So they have hypotension and hypothermia, bradycardia, and hyponatremia, hypoglycemia. Everything is low and slow. So again, in terms of ABCs, airway patency and ventilatory support may be necessary if they're in respiratory failure. We want to monitor continuous EKG monitoring for dysrhythmias. We want to warm their body with warming blankets. They need IV fluid to increase their blood pressure. And the most important thing is that we need to replace their thyroid hormone. So we need to give levothyroxine IV, because that's the quickest way for it to be absorbed. And they will continue to get IV administration until we can bring those levels up and they get into that euthyroid state. Additionally, because they're hypoglycemic, maybe they get IV fluids with glucose in it. Steroids will actually help pull up those glucose levels as well. And then we need to find out why the patient went into myxedema coma. Did they stop taking their medicine? Are they having an infection? What is the reason for this happening? Collaboration with a patient in myxedema coma includes multiple people. They will see an endocrinologist. They may see a cardiologist for the congestive heart failure effects of hypothyroidism. They might see a dietitian because of the weight gain and trying to reduce the fluid volume, for example. Diagnostic tests for a patient in hypothyroidism, again, like I said before, TSH, T3, and T4 are the most important things that we look at. T3 and T4 will actually be decreased, but the TSH will be increased. Right? They might do a thyroid scan as well. They actually, again, it's a nuclear scan that looks for that uptake of that radioactive preparation. If a patient is getting a thyroid scan, they should not be pregnant. Pharmacology is the treatment for hypothyroidism. We need to replace their thyroid hormone, and the generic name of that thyroid hormone is levothyroxine. It is the treatment of choice. So some things to think about with levothyroxine are it must be taken on an empty stomach. Once they start taking it, it could be several weeks, actually almost to a month before the desired response is obtained. Remember that taking too much thyroid hormone could result in hyperthyroidism, so we need to teach our patients the signs and symptoms of hyperthyroidism. So like weight loss, heat intolerance, tachycardia, tremors, irritability. Important information to know about this is it's lifelong. They have to take it forever. And they will actually get their blood TSH monitored to ensure that the dosage is correct. Just so that you're aware, levothyroxine increases the effects of warfarin. So a lot of our older patients that have hypothyroidism also have a history of atrial fibrillation and have or some type of chronic disease process that requires them to be on warfarin. So we just need to think about that, and it can actually increase the need for insulin and digoxin as well. So a lot of these medications have levels that we can monitor, like INR for the warfarin and digoxin levels. So they just might need more monitoring of their other medications and leveling. In terms of lifespan considerations, again, there are patients, newborns, that can get hypothyroidism. It's congenital. It's one of the most common and preventable causes of intellectual disability. And so if it's undetected, the lower the IQ can be later in life. So it's important that we're paying attention to this. Most newborns with congenital hypothyroidism have very few clinical manifestations of thyroid hormone deficiency. So luckily, this is one of the things that we do a heel stick newborn screening for, so super important. In terms of pregnant women, it can occur, it's often caused by Hashimoto's disease. Again, it's autoimmune disease that's either inadequately treated or from prior destruction or removal of that thyroid gland. We also want to control hypothyroidism during pregnancy because it can lead to miscarriage and low birth weight and stillbirth. So it's super important that we manage their thyroid hormones. And again, levothyroxine is safe for pregnancy, so it's important that they take their synthetic thyroxine for the well-being of the fetus. Our consideration, though, is really in older adults. So a lot of times the thyroid gland, as time goes on, there's some degree of atrophy, it becomes fibrotic, and that's right, kind of normal process during the aging process. So all older adults are at risk for hypothyroidism. It's one of the most common endocrine disorders, but it's also misdiagnosed. So it's really kind of important to pay attention to their signs and symptoms. And we do treat them with levothyroxine, but we're just a little bit more cautious. They may get a decreased dosage to start with, and they're more at risk for cardiac dysrhythmias and angina and MI. So we're just a little bit more cautious with them. We're more conservative with older adults. So in terms of assessment, again, we need to think about what the patient is stating. Are they having trouble with constipation? What does their normal day look like? Are they more fatigued? And then their physical exam. So we're assessing for weight gain, and you can look at the goiter, get some information regarding their cardiovascular status, like their vital signs, their blood pressure, and their heart rate. And in terms of nursing diagnoses or problems, cardiac output is going to be decreased because of that low heart rate and blood pressure. They're going to be constipated. They're going to have some impaired skin integrity, that dry skin with edema. Their thought processes are going to be a little bit altered. Remember, they might have a little confusion or memory impairment. They're slow to respond. They could have low self-esteem because of the weight gain and the goiter. So it's just some things to think about. So really important that we want them to not exhibit any arrhythmias, and that their vital signs are within normal limits, that they can kind of participate in their normal activities, and they'll have a normal elimination pattern. We want to prevent complications such as a mixed edema coma. So implementations go back to monitoring cardiac output and ensuring that they're chilling increases metabolic rate and puts stress on the heart, so making sure that they're dressed for the temperature, alternating periods of activity with periods of rest, having them report any chest pain or heart palpitations. We want to prevent constipation by encouraging fluid intake, encouraging activities as tolerated, maintaining a high fiber diet. Skin integrity is just, they should be taught how to take lukewarm baths instead of hot water because it'll dry the skin out more, or using some alcohol-free skin oils and lotions for that dry skin, for example. In terms of evaluation, again, back to is their elimination patterns within normal limits? Do they have any vision issues? Does their skin remain intact without edema? Are they having normal vital signs? And they can establish those at both rest and with activity. And if none of these evaluations are being met, we need to really look at their TSH levels and see if their levothyroxine is being taken, or if they may need an increase or decrease in their dosage. Thank you.